A 72-year-old woman falls while at home and lands face down. She is unable to get up and remains prone on the floor overnight until a neighbor notices her and calls 911. She is taken to the emergency department where she is noted to have several hematomas on her face and a large hematoma on her right upper thigh. On physical examination, the patient is unable to flex her right hip or extend her right lower leg. Patellar reflex cannot be elicited on the right knee. Patellar reflex is normal on the left side. The patellar reflex, also called the knee reflex or knee jerk, is a stretch reflex which tests the L2 to L4 segments of the spinal cord. Leg adduction and abduction are intact bilaterally. What is the most likely diagnosis? The most likely diagnosis is femoral neuropathy. Femoral nerve damage, also referred to as neuropathy, can occur from an injury or prolonged compression. The anatomy of the femoral nerve. The femoral nerve arises from the lumbar plexus, L2 to L4, and travels through the pelvis. Muscular branches are first given off to the hip flexor, psoas muscle, and then to the iliacus muscles. Sometimes they known together as the iliopsoas muscle. At the level of the thigh, it begins to pass lateral to the femoral artery, behind the inguinal ligament, dividing approximately 4 centimeters below the inguinal ligament into the anterior superficial and the posterior deep divisions. The anterior division of femoral nerve. It gives muscular branches to the sartorius hip flexion, knee extension, and pectineus muscles, hip flexion. The anterior division supplies sensation to the anteromedial thigh. The posterior division of the femoral nerve. The posterior division innervates the quadriceps muscles. Quadriceps are a group of muscles present on the front of the thigh. They consist of 4 distinct muscles: the rectus femoris and the vastus lateralis, intermedius, medialis. The quadriceps muscle group plays a vital role in knee extension. Posterior division gives rise to the saphenous nerve, which provides sensation to the anteromedial knee, leg, and foot. In this case, weakness of the quadriceps muscles and hip flexors, which are innervated by the femoral nerve, and lack of patellar reflex suggest femoral neuropathy. The cause of the neuropathy in this case is a hematoma, secondary to trauma, compressing the femoral nerve. Because both the hip flexors, L2 to L3, and the quadriceps muscles, L3 to L4, are involved, the nerve is affected above the inguinal ligament. If the compression had affected the femoral nerve distal to the inguinal ligament, where the femoral nerve branches into the anterior and posterior divisions, a deficiency in either the hip flexors, anterior, or the quadriceps muscles, posterior but not both, would be expected. What sensory defects are expected in this patient? The femoral nerve innervates the skin of the anterior and medial thigh. Thus, light touch sensation is decreased in these areas. The lateral aspect of the thigh is innervated by the lateral femoral cutaneous nerve, L2 to L3, and is spared in an isolated femoral neuropathy. The saphenous nerve is a cutaneous branch of the femoral nerve that arises from the femoral nerve in the femoral triangle. It innervates the skin of the anteromedial knee, leg, and foot to the medial side of the big toe. Because this lesion is above the femoral ligament, the saphenous nerve distribution is also involved. What other structures are found in the femoral triangle? The femoral nerve is the largest branch of the lumbar plexus and, after forming in the abdomen, runs posterolaterally to the inguinal ligament. It crosses under the inguinal ligament lateral to the psoas muscle and enters the femoral triangle. In the femoral triangle, bounded by the sartorius muscle, inguinal ligament, and adductor longus, femoral nerve runs lateral to the femoral artery, which is lateral to the femoral vein. The vessels are enclosed within femoral sheath, and the nerve is outside it. Femoral triangle dissection. Navel, femoral nerve, femoral artery, femoral vein, empty space, site of possible femoral hernias, and lymphatics. Why is thigh adduction spared in this patient? The major muscles responsible for thigh adduction are the adductor longus, adductor brevis, adductor magnus, and the gracilis, which are innervated by the obturator nerve, L2 to L4. Because this is a peripheral neuropathy, not pathology of the nerve root, the obturator nerve is spared and so is the thigh adduction. What other clinical scenarios can be associated with femoral neuropathy? Diabetic vasculitic damage, direct penetrating trauma, hip fracture, iliac aneurysms, incorrect placement of the femoral line, prolonged hip flexion during gynecologic or urologic procedures, and tumor. What is Meralgia paresthetica? Meralgia paresthetica is a type of femoral nerve dysfunction that affects the lateral femoral cutaneous nerve. This portion of the femoral nerve gives sensation to outer side of the thigh. The symptoms of Meralgia paresthetica include burning, tingling, or numbness, specifically on the skin of the thigh. This type of femoral neuropathy is usually caused by repetitive leg motions, hip injuries, weight gain, or wearing tight belt. What is the treatment of femoral neuropathy? Most patients with femoral neuropathy can be treated conservatively with physical therapy, avoidance of excessive hip abduction and external rotation, and knee bracing to prevent buckling of the knee. In cases of painful femoral neuropathy, neuropathic pain medications may provide benefit.